Thank you.
Morning. Good morning. This is Dr. Shetty and the Pro Chancellor.
Good morning.
Dr. Badwe. Nice. Nice. Yeah. I'm basically an orthopedic surgeon.
Right. Who will be the audience for this?
All our staff and many of the oncologists.
Okay. Great.
All our staff, there are about 200 staffs who are part.
Right.
So good morning.
Good morning.
Dr. Satish Bhandari here.
Pleasure
How are you,
meeting
sir?
you. Very fine, thank you. My apologies for this little change from 14th to 13th.
No,
But, you know, tomorrow we have this the governing council meeting of Tata Hospital, which allows me to get the funds for the whole year, and it's just not possible that I can change that.
I know. It is great. Tomorrow, actually, we had a puja also, Vijayadashmi. So it is.
Oh yes, of course.
Hospital there, particular of the Ayurveda puja and all that. So
True. My slides can be run from the other end, from your end, I suppose. I spoke to somebody that the slides can be run from there, and I will. There was some problem with my slides coming up from my end.
So I think they should be able to.
Yeah.
Yeah, that's fine. Dr. Ajay Puri is still with you, or he? Dr.
Yes,
Ajay Puri
he's very much there, and we're not going to leave him so soon.
No, yeah, he was also in practice. Somebody told me. No, we meet quite often because of even last month we had a combined virtual together in orthopedics.
Yes,
He's a great speaker. He's a great speaker.
Orthopedic oncology is quite a niche area, and that not many orthopedicians want to get into that.
I know. That's it. Lot of scope and the survival and even the whole thing has changed. So
Absolutely, it has changed remarkably.
the survival rate has considerably gone up.
Sir.
Ready?
Ready, sir. Sorry. I'm extremely sorry for the some connectivity problem from our side. Sorry, sir.
You must say sorry to.
Sorry to Badwe, sir. Sorry, sir.
No, that's absolutely fine. I was wondering. I thought there was some problem at my end, and I was unable to get through to that.
Yeah.
Okay, we'll start, sir.
Yeah,
Sure. Sorry.
Thank you, sir. Thank you. Good morning to one and all. We, the Office of the Research Directorate, Nitte, deemed to be university, are very much delighted to welcome you all for the today's event, the Leela Narayan Shetty Oration, Breast Cancer, a Model for Cancer Research and Treatment. Breast cancer is the leading cause for cancer death in women worldwide. At the same point, rapid advances in the breast cancer research in the last 10 to 15 years has identified the respective protein receptors, which drives the cancer, and therapy against that has decreased the mortality. In Indian scenario, because of late detection and increased triple negative breast cancer cases, so without any therapeutic molecules, and also resistance has increased the mortality rate. During this Breast Cancer Awareness Month observation by Nitte, we wanted to have one talk by a clinician, especially oncosurgeon. In this respect, I have approached Dr. Rajendra Badwe sir, and even though with these busy commitments, he has readily agreed for this. Our speaker for today's function, Dr. Rajendra Badwe, a leading oncosurgeon and the director of Tata Memorial Center, Mumbai, is with us today. Warm welcome to you, sir.
Thank you.
To grace this occasion, we have our esteemed Vice Chancellor, Professor Dr. Satish Kumar Bandari, as a chief guest for this function. We also have with us our guest of honors, Dr. Shantram Shetty, sir, Pro-Chancellor, Nitte deemed to be University, and philanthropist Dr. K. Narayan Shetty, diplomat of American Board of Internal Medicine and Cardiology. We also have Professor Dr. Jaiprakash Shetty, Vice Dean, K. Segde Medical Academy, and Dr. Shivkumar Hiremat, Medical Superintendent, K. Segde Charitable Hospital with us. I extend a warm welcome to all the dignitaries and the participants for this Breast Cancer Awareness Month. Our guest lecture. Our beloved Vice Chancellor, Professor Satish Kumar Bandari, is a well-known personality in the field of otorhinolaryngology. He has occupied various positions in our university as professor and head of the department ENT, followed by the Vice Dean and as a Dean of K. Segde Medical Academy. He is the recipient of various honors and awards, to name few, like Aryabhatta Award for Excellence in the Field of Medicine by Aryabhatta Cultural Association, Bangalore in 2006, FRCS from Derek Alderson, President, Royal College of Surgeons of England in 2018, etc. Sir is an active surgeon and an active researcher. So I request you to deliver the opening remarks on this occasion of breast cancer lecture. Please, sir.
Very good morning. Distinguished guest for the day, Dr. Rajendra Badwe, Director, Tata Memorial Center, Mumbai. Dr. Narayan Shetty, renowned physician and philanthropist, good friend of mine from USA. Professor Dr. Shantram Shetty, our Honorable Pro-Chancellor of Nitte deemed to be University. My colleagues Praveen, Hiremat and Jayaprakash, faculty of Nitte deemed to be University. My dear students and delegates for this webinar. Greetings from Nitte deemed to be University. Nitte is the name of a village. It's our founder's village. Justice K. Segde, former Supreme Court judge and Speaker of Lok Sabha, after very distinguished 40 years of his public life, retired from his active service and retired in his village, Nitte, and started a school and a trust to empower the local youth. The seed which he has sown about 42 years now has become a big mega tree with more than 36 institutions spread out in 3 campuses with more than 20,000 students and 4,000 faculty. Nitte deemed to be University is one of the youngest offshoot of Nitte Education Trust. We had just started in the year 2008. In the last 13 years, we have created become a reputed university in the country with the NAC A+ accreditation and one among the 77 in the NIRF ranking, which was declared recently, under the able leadership of our Chancellor, Shri N.V. Hegdeji. It's my privilege to welcome you all to the inauguration of Breast Cancer Awareness Month and also to Leela Narayan Shetty Memorial Oration organized by the Nitte Education Research Directorate in collaboration with our hospital, K.S. Hegde Charitable Hospital. It's indeed a momentous occasion as our flagship institute, K.S. Hegde Charitable Hospital, 1000-bed super specialty hospital, is celebrating the best Breast Cancer Awareness Month in a very meaningful manner by conducting various activities like cancer detection camps, free mammography in the hospital for the public, and talks by eminent people. And today's guest oration, it's in the same direction, by very renowned cancer specialist, Dr. Rajendra Badwe. This oration is named after late Leela Narayan Shetty, wife of Dr. Narayan Shetty, renowned physician and philanthropist from USA, in whose name our cancer hospital in the campus is named after, and our neurological research center also is named after Leela Narayan Shetty. As you all know, breast cancer is one of the most common form of cancer in women in Indian in the country. About 14% of the cancers in women is due to breast cancer, I understand. According to the recent report published by National Cancer Registry, it estimates that the cancer is rising rapidly. It is going to increase from the present 14 lakhs to 16 lakhs in the year 2025. That's almost a 20% increase in the number of breast cancer cases. As per the report, every 4 minutes, an Indian woman is diagnosed with the breast cancer. There's a lot of misconception about cancer among the people and a lot of negligence also. The statistics show that about 70% of the cases present in the advanced stage, and because of that, they got very poor survival and there is high mortality in breast cancer. Breast cancer is a treatable cancer and chance of survival is higher if it is detected very early. Unfortunately, in India, has got a low survival rate due to late detection, which can only overcome by increasing awareness about breast cancer. This early detection can only be possible from providing public health education to improve the awareness about the women in women about signs and symptoms of breast cancer, and understanding the importance of early detection and the treatment. More women should be informed or educated about through medical practitioners about breast cancer and early detection. Public education also needs to be combined with health worker education, because they're also important part of this education program about the signs and symptoms of breast cancer. Like teaching self-examination of the breast and encouraging periodic mammography examination by women are important initiatives so that cancer can be detected early and we can treat early and cure the cancer early. Today's talk by our very distinguished eminent cancer specialist, Dr. Badwe, is the right step in this direction. I congratulate the organizers for selecting this topic, breast care, a model for cancer research and treatment. I congratulate the hospital for organizing this month-long cancer awareness. I understand this is a month-long program. They are organizing various activities like free mammography for the public and free consultation and free treatment also in early diagnosis, like taking biopsy and whatever needed investigations also done in the hospital. And they're also collaborating with the local NGOs and women clubs in creating awareness about breast cancer. I thank distinguished speaker for today's program, Dr. Rajendra Badwe, Director, Tata Memorial Center, for accepting our invitation to deliver this prestigious Leela Narayan Shetty oration. And his biodata will be read by another colleague. I thank you, sir, for participating in this program. I hope all the participants will be benefited by his talk, and they will carry very pleasant memories of this webinar. I welcome our friend, philanthropist, respected physician from USA who is joining virtually for this program. And I thank our respected Pro-Chancellor program. Thank you, sir. And I thank all my colleagues who have toiled to make this webinar and oration a success. Thank you very much. I wish all the participants a great time. Stay safe, stay healthy. Thank you very much.
Thank you, sir. Thank you, sir, for the insightful remarks. Sir, in his opening remarks, has shed a light on our trust in the breast cancer statistics and our breast cancer awareness program from K.S. Hegde Charitable Hospital. Our Leela Narayan Shetty Cancer Hospital is initially supported by philanthropist Dr. Narayan Shetty and family. Leela Narayan Shetty Cancer Hospital, which will support breast cancer treatment to poor patients and breast cancer research, among others. As this program is about breast cancer awareness, so we wanted to convert this into oration in the name of this cancer center. Our Pro-Chancellor, founding Dean of K.S. Hegde Medical Academy and first Vice Chancellor of Nitte, Dr. Shantaram Shetty, who has been a constant support and part of our every endeavor. We are very lucky to have him with us today. And I request him to introduce our guest of honor, Dr. Narayan Shetty. But Narayan Shetty, sir, because of his personal commitment, so last minute, he said he could not join. So in his absence, so I request Shantaram Shetty, sir, to say a few words about Dr. Narayan Shetty. Please, sir.
Thank you. Good morning to everyone. Our esteemed guest speaker, Dr. Rajendra Badweji, our Vice Chancellor, Dr. Satish, and all my colleagues in the university. It is indeed my privilege to just place before you the achievements of Dr. Narayan Shetty, who was instrumental in developing our neurology center and also the cancer center in our university. Dr. Narayan was born in Kandavar in an illustrious one family. He had his early education, medical education in Kasturba Medical College, Manipal. Then he migrated to Mumbai and he was the registrar in Sion Hospital. Then he migrated to United States in 1964 and he never looked back. And he did his residency program in the Mount Sinai Hospital in New York. And then he did his both in cardiology, both in internal medicine and cardiology. Then he settled down in Pittsburgh in Alacopa Hospital, and he served this hospital for nearly 42 years. And he retired as the director and the president of that particular hospital. And he is a well-known cardiologist of that part of the United States. And more than all, what is unique about him is that whatever he believed in the philosophy of Judge Bernard Shaw, that whatever we leave behind our footsteps, and let me not be a small little lamp to wither away at the end of the day, but let me be an illuminating lamp to illuminate the lives of my fellow men. That was the philosophy of Dr. Shetty. And as a philanthropist, he has donated immensely all around the United States and in his village, and including a huge amount of money for our university in establishing the neurological center, which is one of the latest centers, up-to-date centers in this part of the country, and also the cancer center, where almost every modality of cancer treatment we have instituted, and we are getting into a PET scan very soon. So people like Narayan Shetty really leave behind their footsteps, and I thank him on behalf and it was in the name of his wife that he donated, Leela Narayan Shetty, who happens to be my first cousin, and he donated all this to remember her fight against cancer, which she herself was a patient. And today, to remember her, we have this oration in her name, and we are very lucky that one of the foremost experts in the country and in the world, Dr. Rajendra Badwe, is sharing his thoughts on this very important subject on breast cancer, a model for treatment and research in cancer. We thank you, Dr. Badwe, for for this great time you could spend in spite of a very busy schedule. On behalf of all of us and the university, we are extremely grateful to you. Thank you very much. We go on with your lecture. May God bless you.
Thank you, sir. Thanks, sir. Thanks for your kind words and the information about our cancer center. So how it was initiated, how it is working to help the important social cause. When we planned this program, so we thought of inviting a practicing clinician, as I mentioned, as a speaker. In this regard, so Dr. Badwe sir, one of the leading oncosurgeon of this country, is the best person for this event. So personally, I was following sir's research work, and the last time, in Banaras Hindu University, I witnessed his, so just before COVID, the talk was on act of observation in cancer. I think, so we are very blessed to have him with us today. And I request our Vice Dean, Dr. Jaiprakash Shetty, to introduce Dr. Badwe to the participants. Please, sir.
Esteemed the orator of today's ceremony, Dr. Rajendra Badwe, respected Pro-Chancellor, Vice Chancellor, and all my colleagues at university and in the medical college. It deemed it my indeed great privilege to introduce one of the renowned personality in the South India, Dr. Rajendra A. Badwe. He's an expert in the field of oncology. His opinions are reportedly considered for devising cancer care strategies, disease management, and research protocols worldwide. Dr. Badwe has worked in many institutes, to name a few: the Toraman Hospital, Tokyo, as a fellow of International Society of the Diseases of the Esophagus, the Guy's Hospital, the King's College of London School of Medicine, and Royal Medicine Hospital. His contribution in the areas of breast cancer, the circulating tumor cells, the DNA in solid tumors, clinical research methodology, epidemiological research in oncology are reported to have enabled a better understanding of cancer biology in the development of life-saving treatment patterns globally. He has also completed first ever randomized clinical trial in India for 1,000 breast cancer patients whose outcome has potential of saving thousands of lives with a low cost of $2 per patient. He has several scientific committees globally. He is one of the members. Besides being a reviewer to several international peer-reviewed cancer journals like Lancet and British Journal of Cancer, he has over 100 publications to his credit. Dr. Badwe, for his human work in the field of cancer, has conferred with Padma Shri National Award for the contribution of medicine, and also the prestigious Lal Bahadur Shastri National Award for excellence in the public administration and academics management, President of India in 2013. Currently, Dr. Rajendra Badwe is the director of Tata Memorial Hospital and head of the Department of Surgical Oncology at Tata Memorial Hospital, Mumbai. Sir, here on behalf of Nitte Deemed University and K. Sigde Medical Academy, we proudly present to you for your guest lecture on breast cancer, a model for treatment and research in cancer. Over to you, sir.
Thank you, sir. Thank you, sir, for the brief introduction of Dr. Badwe, sir. Now I request Dr. Badwe, sir, to deliver a lecture on breast cancer, a model for cancer research and treatment. Please, sir.
Thank you. Thank you very much. The Vice Chancellor, Dr. Satish Kumar Bhandari, the Pro-Chancellor, Dr. Shantaram Shetty, the philanthropist from US, Dr. Narayan Shetty, and the Director for Research and Development, Dr. Praveen Kumar Shetty. It is an honor to present this oration in the name of Leela Narayan Shetty, to be here with you, sharing my thoughts. And let me start off with saying that in a lot of my talks, I am quite heretical. I tend to flow away from what the routine is, so that there is some bit of constructive destruction that happens in the brain cells for us to think differently. And breast cancer is one of the finest examples where things have begun and been followed in many other cancers. Can I have my next slide, please? So there are various examples wherein breast cancer has been the vanguard. From radicality to conservatism, organ preservation has begun in breast. It has been translated in almost all other sites, may it be urinary bladder, may it be limb salvage. And there are various places where we have become extremely conservative after first being successful in breast. The adjuvant treatment, whether radiotherapy or systemic therapy, has been first proven to be effective and life-saving in breast cancer. And from there, it has gone to many, many other areas. Screening is also one such example. Genetic testing has originated here. I will not allude to any of these. From there, I would like you to be taken to a new paradigm, which earlier Dr. Shetty had mentioned. He heard me talk in BHU. We have evolved from there into some more studies, and I will allude to that so that there is a little bit of kind of thought, food for thought, as we get on with understanding breast cancer. Next slide, please. So let's look at, if I look at the disease-free survival curves of patients who present with breast cancer, there are a very small percentage who present with metastatic disease at presentation. A great majority are M0 at presentation. So when I looked at the Tata Hospital data way back in 1985, the numbers at that time were approximately 10% would present with metastases at presentation without any treatment. Now, in those days, I was looking at records from 1970 to 1982, when I'm speaking about 10% at presentation. The average tumor size was 7 centimeters. From there on, I went to UK at Guy's Hospital, and I had the opportunity to look at the Thames Cancer Registry data. Now there, the tumor at presentation was, in those days, 3 centimeters. So ours was 7, theirs was 3 centimeters. And the metastases at presentation in Thames Cancer Registry database was 6%. Now, I just couldn't believe that the tumor has grown from 3 centimeters to 7 centimeters, and the metastasis at presentation has increased from 6 to 10. If I were to treat this lady for 3 centimeters, her chance of survival was anywhere up to about 70%. But if I were to treat a 7 centimeter tumor, the chance of survival was barely 25%. So metastasis would present in such a huge numbers, a difference which was close to 50% in metastatic disease. Whereas I allowed the tumor to grow in vivo, the increase in metastasis using the same technology, bone scan, liver scan, all state of art, was barely 5%, 4% increase. So was the body not allowing the metastasis to be presented or metastasis to grow elsewhere? What is it? So such a huge difference was not easily understandable, and I had major difficulty coping with it. So let's look at how did we think. All this time we believe, today we believe the Fisherian hypothesis that micrometastases originate prior to surgery, not detectable by staging investigation, and are unaffected by surgery. If they're there, they'll grow, and we try and treat them. As against that, if I were to say that micromets were actually induced at the time of surgery, mark my words, at the time of surgery, it may not be surgical intervention, something else might be happening, and I'll allude to that. Next slide, please. And why did I think of this? This is the data I mentioned just now in Thames Cancer Registry. This is the data from United States. This is SEER database. Look at that red line. It is almost a straight line. Since 1976, late stage disease M1 at presentation has hardly changed. From 100, it is to 96 or so. Whereas the early detection tumors have gone from close to 104 to 250. That many incidence increase per 1 lakh women has happened, but the late cancers have not reduced. So what are we achieving? Is late cancer not a manifestation of late detection, or late cancer in M1 is an a priori? Next slide, please. So we need to relook at this. So I mentioned the Fisherian hypothesis, which was based on the NSABP B04 and B06, wherein the treatment of lymph nodes did not impact on the outcome to begin with. We now know that it does impact. So the micrometastases, we decided that we'll treat them with adjuvant treatment, and the bracket numbers are the benefits out of adjuvant treatment. 1% to 10% improvement. It is a modest improvement. I can't say that there is no improvement, but I must say that we were looking at killing micrometastases. We are successful in a small proportion, 1% to 10%. Can we beat micrometastases? If it was happening just before surgery, then can I shift the diagnosis to the left by screening? And what happened with the screening? No benefit less than 50. Mammography showing no benefit below 50. And above 50, a 25% relative reduction in death, which is quite sizable. But the all-cause mortality remained 1.1 in screening. So there was an increase, about 1%, 10% increase in mortality overall, all cause. So if I were to do screening, I will have to tell the lady, yes, your chance of dying of breast cancer will be reduced 1 in 4, but the chances that you will die otherwise at the same time that you were destined to die doesn't change at all. So I must say that this success is not very great. Unlike these numbers which are mentioned there, 25% reduction in deaths related to breast cancer, no difference in all cause. For cervical cancer screening, there is a 30% reduction in deaths related to cervical cancer and a 9% reduction in all-cause mortality. So if screening was to really help, a little reduction in all-cause is equally important, because you screen only common cancers. You don't suddenly screen uncommon causes. Like in middle of Mangalore or middle of some Karnataka city, one wouldn't start looking for a tiger. One would look for some common animal. So it's something like that. If that's the common disease, why isn't all-cause mortality not reduced? So we need to revisit. Next slide, please. So we need to revisit this database. And to review this hypothesis, as already mentioned, that is there a possibility, the second possibility, that is actual surgical dissemination or autonomy happening? Let's look at what is the data. Next slide, please. We got this hypothesis earlier from Fisher. Fisher stated that surgery didn't make a difference. Here is an experiment that Fisher himself carried out in 1989, published in 1989. So the gentleman knew what he had said needed to be tested. So he started off with what's there in the first mouse, that an implant was created. Once the tumor grew, he created another small implant and called that a micrometastasis, and then undertook surgery for the larger tumor. The moment the primary tumor was removed, the other metastasis grew. So his hypothesis was that there was a growth advantage bestowed on the secondary tumor when primary is removed. So imagine the father of our hypothesis, the generator of this hypothesis, himself was not too sure. Is it happening before surgery or is it happening around surgical time? So that's his experiment. Next slide, please. But we don't have any human experiments on this. He also looked at animal experiment to find if the growth potential improved. And there is a growth potential that improved. The first 4 lines in the first graph is up to the point of surgery. Then 4th point is the point of surgery, and post-surgery, the growth potential improved remarkably as seen by the thymidine labeling index. That's in the first graph. And in the second graph, it is also seen that the top graph is untreated tumor. As soon as surgery is done, the vertical line in the middle, there is a rapid growth of the tumor. The growth potential increased. It had reduced by chemotherapy at the bottom graph, but post-surgery again it began to rise even after chemotherapy. The middle graphs are the ones that happened with tamoxifen and LHRH agonist. So hormone therapy did not induce this upward progression of growth, but the other 2 did. Next slide, please. So again, Fisher's experiment. Fisher himself said this, that surgery didn't make a difference, but in his mind, he was exploring that it did make a difference. Let's look at the next slide, please.
Just see them.
Can I have a next slide? Next one, please. So impact of events at the time of surgery is what we are looking at. The next one, please. So it will be unethical to do a trial of surgery versus no surgery. But the second best opportunity we have is to compare data of screened versus unscreened. And I'll tell you why. Next slide, please. Any screening trial assumes that in the screened arm, there are some early tumors, equal tumors between screen and control, X number of early and Y number of late tumors on both sides. In the screened arm, all are treated. In the control arm, only late tumors are treated and early tumors are allowed to grow till they become manifest late, and then they are treated. So early years is all treated versus few treated. And late years is early treated majority and majority treated late. So late versus early versus late is what the late years of follow-up, but early years of follow-up should be that all treated versus some treated. That means some not treated. Treatment versus no treatment can be tested in early years. In routine course of events, if I were to look at Fisher's hypothesis, there should be equal deaths on either side and later on lives saved by screening. Let's see what has happened. Next slide, please. So in routine course of events, by Fisher's hypothesis, I should have had equal mortality in early years, and by SDA, the surgical dissemination hypothesis, excess mortality in early years, whereas late years, lives saved in both hypotheses. Let's look at what has happened in reality. There are many screening trials. Next slide, please. This is breast cancer screening trial, and you will find there are too many figures here, but anything which is above 1 indicates death, excess death in screened arm. And you will find that the top 5 years of lines, there is excess death in screened arm in below 50. And the first year of above 50 also has excess deaths in first year. So there are excess deaths happening in screened arm in early years in breast cancer. Next slide, please. Let's see if this has happened. This has happened in lung cancer, 6 trials, everywhere early excess mortality. Cervical cancers, early excess mortality. Prostate cancer, 3 trials, early excess mortality. So there is no trial where early excess mortality doesn't exist. Next slide, please. I'll show you 1 or 2 graphs. This is the American trial, wherein screening versus not, the left-sided is the incidence of cancer, and the right-sided is the deaths related to cancer. And the screening has greater deaths, even up to the end of 9 years, that there are excess deaths in prostate, and nobody screens prostate cancer today in the Western world. Next slide, please. This is our own study of cervical cancer, and you will find that the top graph to begin with is the screen graph, which crosses over and saving of lives. So early years, year 1, year 2, year 3, excess mortality in the screen arm, and lives saved later in life. Next slide, please. Our own trial of breast cancer, again the same. Early years, excess mortality, late years, saving of lives. So it's uniform. Everywhere, this is what has happened. Next slide, please. What I would like to see is that if that has actually happened, is there a human experiment where we can see that this has actually happened? Next slide, please. So we ran a study in individuals who presented with metastatic breast cancer. We treated them with chemotherapy, and it is not a standard of care to operate when patients present with metastatic disease. It's usually said that unless there is fungation, nobody operates. So we ran a randomized study. Post chemotherapy, next slide, please. Next, stratified for these factors, next one. And we randomly allocated. Next one, please. Yes, to surgery versus not. So there are two parts. The green part is all those who had, half of them had surgery and half of them did not have surgery. Because surgery is not the standard of care in those who present with metastatic breast cancer. What happened next? Next slide, please. Excellent local control in those who had surgery. The green line is loco-regional surgery, fantastically good local control. Look at the difference. It is somewhere to the tune of about 84% difference in local control. The lady had fantastic, good local control. Next slide. Did you see the green line going down here? This is metastatic progression. Metastatic progression happened rapidly in those who had surgical intervention. So this is the first randomized evidence globally published in Lancet, and there is a clear evidence within human experiment that those who present with metastatic disease, if primary is removed, the metastases grow faster. So that's what had happened in this trial. So what we saw in Fisher's animal experiment was actually happening in human breast cancer. Next slide, please. So events at the time of surgery did make a difference. That's the Lancet Oncology paper. This was the first trial globally that set the standards for treatment of metastatic breast cancer and also gave us some insights into biology of breast cancer. Next slide, please. Then the next thing, we now have evidence that probably something happens at the time of surgery. Then can we do something to tweak around the time of surgery instead of doing something long after surgery and treating micrometastases? So we ran a study. Next slide, please. A simple study. And the study was that movement of cell happens normally, physiologically in menstrual cycle. So an ovum leaves ovary and goes into the uterus to create another human being. Cell moving from one organ to the other. What is it? Metastases. Metastases needs cell to move from primary organ and go somewhere else. What's the incidence of a dizygotic twins? That means two ova coming up. Extremely rare. So obviously there must be a switch that stops movement of cell the moment first cell is extruded. The first ovum is extruded. And that switch is the moment the ovum comes out, the lining epithelium of that corpus luteum is formed, which starts secreting progesterone within seconds. Within seconds. And that is what stops a second ova being extruded. All twins, a great majority of the twins are monozygotic. That means two sperms producing the two children, but only in one ovum. Whereas a dizygotic twins is extremely rare. Non-identical twins I'm talking about. So we did a trial of 1,000 patients. 500 of them got a single injection of progesterone, $2. In those days, it is, now it's about 100 rupees. Half of them received, and there is a 10% outcome difference in disease-free survival and overall survival. 10% lives saved by $1 or $2. That's the evidence that tweaking, a randomized study showing that tweaking events at the time of surgery might change the outcome of presence of metastasis. Next slide, please. So what we're trying to see biologically is there something that is changing at the time of surgery? Next slide, please. So we ran another experiment. You can tap 2-3 of them so that I have all the whole slide in front. That's right. That's fine. Okay. So the first is a biopsy we did before I started surgery, a core biopsy, when 50% of the tumor was devascularized. I'm doing breast surgery. Half the tumor surface I have denuded while doing surgery. This is a hypoxic tumor. I do a core biopsy. And then at the end of resection, the tumor is in my hand, completely anoxic. I then do a core biopsy and run an expression profile on each of them. What was my thought? My thought was very simple. I am confronted by 4 goons. What is my reaction? I'm comfortably walking on the street. I have no reaction. 4 goons come in front of me with a threat to my life. My first reaction is, I want to fight. All antennae up, all reactions there. Somewhere down the line, I am overpowered. And I regress. I stop all my reactions because it's a lost cause. I would anticipate exactly the same if I was treating a live organism being extirpated. Next slide, please. So we did an expression profile on these 32 triplets. Next slide, please. Next. Go on to the next slide, please. Right. This is what I would anticipate, that sample A is normoxic, sample C is anoxic, and sample B is hypoxic. I would consider lots of changes in hypoxic tumor and no changes, or getting back to what it was earlier in C. Next slide, please. What did we find? In the first, look at the changes that have happened within 15 minutes of starting surgery. 15 minutes, there were about 1,200 genes that changed in 15 minutes. And what changed was kind of genetic pathways that would increase motility, flight response, fright response, the same as any human being. I want to run away from there if I'm being overpowered. It's exactly the same that every cell, which has a mind which is no different than the host, is trying to do. Next slide, please. To conclude, act of observation did change the tumor, and in sample C, the difference between A and B was 1,200 genes. The difference between A and C was 35 genes. So all those genes which were overexpressed were withdrawn by the time the tumor was in my hand. Please understand, all our biology is based on sample C, a lost cause. And we have missed out on the tumult that happens in the middle. So hypoxia does induce metastatic phenotype on the tumor cells. There is proliferation, there is invasion, there is motility, there is EMT, there is permissive immunological response. Also, the PD-L1 is suppressed strongly in surrounding cells. Next slide, please. So we have had this change years ago. In BC, we thought cancer was a systemic disease. And Gallen was the person who said this. And then we had Halsted, local disease slowly progressing. Between them, Tizzer did some elegant studies in 1904 showing that actual removal of tumor did make a difference. Then Halsted was replaced by Fisher. And again at transition time, Nissenmeyer felt that at the time of surgery, perioperative chemotherapy might change. And now that we are challenging Fisher, there is again an upsurge in what is happening at the time of surgery, because we are debating, when does metastasis set in? What changes? Nothing changes in our understanding, but this kind of thought process will allow us to say that metastasis can be prevented since we have failed in treating metastasis. Metastatic disease cannot be cured. As of today, on the surface of the earth, somebody with metastasis is not curable, and this is not something new. Sushruta in 300 BC had said that there is an Arbuda and Dvibuda. Arbuda is a primary tumor. Dvibuda is a tumor that appears after Arbuda is there, and then Sushruta says that Dvibudha is not curable. Arbudha is curable. Something that is said so many years ago, we still repeat the same. Next slide. I showed you the slide of progesterone. We are doing another study which is finished. 1,600 patients have been randomized to local anesthetic given around the tumor to put the tumor to sleep. Or lastly, we're trying cannabis, that if the host can be in a state of bliss, can we put the tumor in state of bliss while being removed? A stealth attack on the tumor. Next slide, please. And I would stop at that. Thank you very much.
Thank you. Thank you very much.
Thank you, sir. Thank you, sir. Thank you very much for the detailed aspect of screening, effect of early screening, and the effect of resection and the follow-up. Sir, it's already known that one question I'll ask from my side, sir. So prostate cancer, early screening is not good. It is already confirmed.
Yes.
It's already confirmed. So
Yes.
Is that so in all other cancer, sir? Ovarian cancer, breast cancer, and all?
So breast cancer is effective above 50 screening. Cervical cancer screening is extremely effective. Oral cancer screening is also effective in men and women both. Colon cancer screening is also effective, but colon cancer is an uncommon cancer in India. The incidence of colorectal cancer is below 10, whereas that in United States is 60. In UK, it is 60. So 6 times more cancer, an uncommon cancer we can't search for.
Yeah.
Our diet is good and we should stick to that. West is best should not be followed here.
Yeah.
But for other cancers,
any more questions?
For lung cancer, there is no question of screening because it is completely ineffective.
Thank you, sir. Thank you. So any more questions from our panel?
Dr. Badwe, compared to, I'm concerned about our orthopedic patients. Compared to an osteosarcoma, where we do a total resection now and do a reimplantation, complete reimplantation with a total tube. How does it differ? Say the total excision, can't it be done? But how does it, why in breast cancer it differs?
I'm not saying that surgery should not be done. I'm saying that surgery is to be done. But if I were to rephrase this, that it's something that bites only when you hold. And if you leave it, it grows. And when it grows, it bites bigger. So we need to, there's no question we have to do surgery.
That's
and
true.
There is a very strong reason for it. If you look at body's mechanism of getting rid of cancer, which is established, not microscopic, established clinically, such change, if you look at the molecular kind of phenotype of the cancer, genetically, it is something which is not viable. It cannot create its own organism. It has to be dependent on the host. Such fetus, for example, which is genetically not viable, what does body do to it? There is a very elegant study from Oxford looking at spontaneous abortions. And in spontaneous abortions, some accepting, one is not looking at os, incompetence of the cervical or the os. Those abortions are different, but anything else that is spontaneous had non-viable fetus. The genes were not viable. So the body tends to throw it off. So surgery is going to be the treatment of choice for non-viable foreign kind of genome. What we need to do is, can you do something pre-operatively the way we do for thyroid, for example? We do leucozyme to reduce bleeding, reduce size. On similar lines, we should think of something which will, for bone tumors, I would again draw your attention to Mayo Clinic report when they said that they had a sudden increase in the survival when they had their pediatric age group changed from 12 to 18.
First
And
floor.
if you see, at 12, there is puberty. That's the only thing that changes. And there are some elegant studies on various things that can change the tumor, bone tumor. We need to understand what is it that will put the tumor to sleep while we extirpate it.
Dr. Badwe, I couldn't understand the anoxic phenomena which you brought about in the biopsy stage. Anoxic, how do you really do it? Just for my,
So it is essentially a core biopsy that I did when the tumor is completely vascularized. A second core biopsy when half the tumor was denuded while I'm performing surgery. Half the spherical area has been cut of the normal side, not the tumor. The normal tissue is, so that much of blood supply has gone down. And the last tumor, when the tumor is in my hand, is completely anoxic. And again, a core biopsy. And on core biopsies, I look at mRNA, expression of what RNA is expressed more. That's it.
Yeah. Thank you. Thank you.
Role of hyperbaric oxygen, taking the same anoxic and hypoxia. Is there any role for hyperbaric oxygen in a tumor?
One can test that. There isn't any evidence to say that it is useful, but it needs to be tested. I don't think there are any great studies to do that tell us that there may be a difference, but one needs to look at it.
Thank you, sir.
Said that anoxic, that tumor proportion when you resect out, was there any change in the morphologically the quantification of the tumor cells?
No, morphologically there was no change. But again, I'm telling you that between first and the second sample, the time lapse is not more than 10 minutes. I've taken the first biopsy and within 10 minutes, half the tumor is denuded. And in 10 minutes, I have 1,200 genes that have gone up and down, and significantly up and down. And in the next 15 minutes, when the tumor is in my hand, all those 1,200 have disappeared. Only about some 30, 40 are still there.
So that is expression level or just activation? So like maybe phosphorylation, acetyl, maybe.
No, this is expression level. Expression
Level.
mRNA, messenger RNA, quantitative estimate on the next generation sequencing.
Okay. Thank you, sir. Any more questions? Any questions? Thank you, sir. Thanks for
Thank you.
Thanks for highly informative talk, sir. Thank you very much.
Thank you. Thank you very much.
Thank you, sir. I request our medical superintendent, Dr. Shivkumar Hiremat, to deliver the vote of thanks. Please, sir. Hiremat,
respected Professor Rajendra Badwe, sir, the distinguished speaker of our program today. Respected Pro-Chancellor, Professor Shantram Shetty, sir, Dr. Narayan Shetty, sir, our Honorable Vice Chancellor, Professor Satish Pandari, sir, all the faculty, all the students of the university who have logged in today to witness, to hear this. Very good morning to all of you. It's my privilege to be asked to deliver this vote of thanks on this occasion. I express my profound gratitude to our Chancellor, Mr. Vinay Hegde, and our Pro-Chancellor, Mr. Vishal Hegde, for their constant support, and without which it would have been very difficult for us to organize this. And my thanks to them. On behalf of the Nitte University, all the teaching faculty and the non-teaching staff, and all the students, and on my own behalf, I extend a very hearty thanks to our distinguished learned speaker, Dr. Badwe, who spared his time, who spared his busy schedule, and consent for giving this wonderful lecture. Sir, thank you very much. In fact, it has enlightened us, and of course, it remembers me of a song in Kannada which says, "Nodiddu sullagabahudu, keliddu sullagabahudu, adre pramanisi nodu anta heltare." That means that the very fact that the observation may change the observed values. So you have given us a lot of insight, including the thoughts that should go for the awareness the prevention, and of course, the thoughts that should go in the screening program also, which I'm sure that everybody agree that awareness, prevention, early diagnosis and treatment are the cornerstones for reducing the burden of the disease. Thank you very much, sir. Thank you for giving us this wonderful insight to organize, in the treatment as well as the screening of breast cancer. Thank you very much, sir. I also would like to extend our sincere gratitude to our philanthropist, Dr. Narayan Shetty, sir, for delivering, for giving us this support in developing the Cancer Research Hospital, and also supporting us in this social cause. I would like to express our deep gratitude to our Pro-Chancellor, Professor Shantram Shetty, sir, for his presence in today's talk. My thanks to our Vice-Chancellor, Professor Satish Bhandari, sir, for his guidance and support. Thank you very much, sir. And of course, I would be failing in my duty if I don't thank all the faculty and staff, and last but not the least, the Research Directorate, the organizers, the IT department, for their support and making this this event to be relayed in this time, during this time where we will not be able to gather together, but then technology has made us connect to each other, and we have been able to get this on to the staff and students who actually needed this. Thank you all. Thank you so much for your cooperation. And once again, thanks for all of us being here. Good day to you all.
Thank you. Thank you, Dr.
Thanks to our Vice Dean, Dr. J.P. Shetty, sir, for introducing Dr. Badwe, sir. I think sir missed there. Thank you, sir.
So sorry. Thank you, sir.
Thank you.
Thank you, sir. Thanks, Dr. Badwe, sir. Thank you very much. Thanks, Shantram Shetty, sir. Thanks, BC, sir. Thanks, J.P. Shetty, sir. Thank you. Thank you very much for your support. Thank you. Yes, sir.
ಅಲ್ಲ ನಾಳೆ ಇವರಿದ್ದಾರಲ್ಲ ಸದ್ಯ ಇದು MS ಇದ್ದಾರಲ್ಲಿ
ಹಿರೇಮಠ್ ಸರ್. ಹಿರೇಮಠ್ ಸರ್.
ಎಲ್ಲ ಪೂಜೆ ಮಾಡ್ಬೋರತ್ತ
ಬರ್ಬಾರ ಸರ್ ಒಂಜಿ 15
we are excluded from attending and banteru above 70 taglu and barpani yet
10:30 ata
15 rekata
ಪೂಜೆ ಅದು ಬೋಲಿ ಸರ್ ಪೂಜೆ 10 ಕಾಣತಾ 10 ಕತಾ 10:30 ಪೂಜೆ ಲಂಚ್ 12:30 12 ಬೊಕ್ಕ ಯು ಕ್ಯಾನ್ 10:30 ಬರಲಿ ಸರ್ ನಿಗಲಿ
ಓಕೆ
ಜಸ್ಟ್ ಸೇ ಹಲೋ
okay then
thank you sir.
Good day. Right, bye. Okay, Praveen.
ಒಳ್ಳೆದಾಯ್ತು ಪ್ರವೀಣ್, ಚೆನ್ನಾಗಿದೆ.
Thank you sir.
It was nice.
Good.
Very interesting and very thought provoking.
Yes.
It's totally different concept. Now early detection ಬೇಡ ಅಂತ ಹೇಳ್ತಾ ಇದ್ದಾರೆ.
Yes sir, that is confirmed in prostate cancer, not in other cancers actually, but sir is telling in all cancers.
It's a food for thought. Research ಗೆ ನೀವು ಒಳ್ಳೆ ಸಬ್ಜೆಕ್ಟ್ ಇದು.
Age onset.
So much is there to study.
Age onset and genetic factors, mainly the genetic. Now a lot of genetic studies are.
Pathology ಅವರು ಸೇರಿಕೊಳ್ಳಿ, pathology ಮತ್ತು ಇವರು ಸೇರಿಕೊಂಡು
ಒಂದು good idea.
ಪ್ರಾಜೆಕ್ಟ್ ಮಾಡಿ.
Tumor if you anoxin.
Anoxia, hypoxic condition, so many genes, so induction takes place because of hypoxia. Maybe that is the reason.
ಅಲ್ಲ ಇದು ಸರ್ ವಿಲೇಜಸ್ ಅಲ್ಲಿ ಈಗಲೇ ಆಲ್ರೆಡಿ ದರ್ ಕಾನ್ಸೆಪ್ಟ್ ಇದೆ, ಕತ್ತಿ ಹಾಕಿದ್ರೆ ಜಾಸ್ತಿ ಆಗ್ತದೆ ಕ್ಯಾನ್ಸರ್ ಅಂತ ಹೇಳಿ. ಸೊ ಐ ಥಿಂಕ್ ದಿಸ್ ಲುಕ್ಸ್ ದಟ್ ಸಿಮಿಲರ್ ಇದರಲ್ಲಿ ಅದನ್ನು ಇದು ಮುಟ್ಟಿದ ಕೂಡಲೇ ಜಾಸ್ತಿ ಆಗ್ತದೆ, ಮೆಟಾಸ್ಟೈಸ್ ಆಗ್ತದೆ ಅಂತ ಹೇಳಿ.
Unless any tumor, if you touch it, other day one simple there was a swelling for one of our patients, small swelling in the forearm. It was there for 10 years. It was growing. It was slowly growing. The old man wanted it to be removed, and within 1 year he died. It was a liposarcoma. He would have lived for another 2 years.
Only removing the primary and leaving the secondary is the biggest disadvantage.
That's right.
ಅಲ್ಲ ಸೆಕೆಂಡ್ ಗೊತ್ತಾಗುದಿಲ್ಲ ಅಲ್ಲ ಜೆಪಿ, ಕಷ್ಟ ಅಂತ ಹೇಳಿದ್ರೆ ಇಟ್ ವಿಲ್ ಟೇಕ್ ಸಮ್ ಟೈಮ್.
The small node will be there is a limit, and that grow exponentially.
Okay,
Okay.
thank you. Thank you very
Thank you,
much.
sir. The live streaming is taking place. We have to switch off. Okay, thank you, sir. You have to log off.
Okay then.
Thank you. Thank you.